The point I wanted to make at the end of my talk about is, I suppose, it's gone to the stage where you finally have to admit you have a senior moment, is it? Is that if we're serious about enabling this kind of translational, exciting work, it would be fantastic if we could finally move on two things in the country. One is, and it was mentioned earlier, a national ethics committee, and the second would be the unique health identifier number. These two things have been talked about in this country for a long time, and we really need to make it happen, because we can't do this kind of personalised medicine and bring in the research, the translational research, because I don't see research as separate. We need these two things to actually happen finally. And that was the point I made. Sorry for blanking.
And if people would like to ask questions, please do. The Slido is open to actually submit questions. I'd like to start with just a question to both Shane and to Norman here, which is about electronic health records and open EHR. And also, I know within your work in epilepsy, you've been working as well with electronic health records. I know the patient identifier is a major obstacle, but what benefit do you see to actually put forward that argument for actually genomics and integrated care, and how important is the electronic health records?
I'm going to kick off that to just really put a big tick behind what Norman has just said there about the individual record identifier. We have that in the north, so it's what's called the health and care number. It's analogous to the NHS number in the rest of the UK. And this has actually already allowed us to unlock a lot of stuff with our electronic health records. We have a system in the north called the Northern Ireland Electronic Care Record, or the NIECR, it pulls together all the letters, all the radiology, all the labs, all the appointments data for every patient in Northern Ireland from whatever trust they're seen in. So if I'm seeing a patient in my clinic in Derry, I can find, if they've been seen in Belfast, I can find all that information there, and it pulls it together. It's not a workflow system, but it does allow me as a clinical geneticist to start pulling together bits of info that I wouldn't have otherwise been able to get, or I would have had to phone somebody to get, or write to somebody to get. So that does really accelerate stuff. The big problem, I suppose, is with that kind of a system is that it's not delivering your workflow, and it's not gathering the data in a format that you can then use readily for the sort of artificial intelligence and clinical decision support analytics, and moving on to the next step that you would really like. So, we've seen a glimpse of the future, if you like, and we know that we need to do more. So it's why I'm really excited, for example, that CHI is moving ahead with the EPIC in the same way as we're going to be in the north, because I think that's going to open up a lot of opportunities.
We developed a bespoke epilepsy electronic patient record way back, actually with the help of the HRB initially, and it's now funded by the system, and it's used in many of the different complex epilepsy centres, and we use it in RCSI for appropriate research, and it is a real live tool. We use it in the clinic. We generate letters, and we couldn't, and our nurse practitioners have been brilliant in enabling this as well. But I couldn't imagine doing our work now without it. I mean, it's just incredible. You click on the patient's name, and you basically the whole summary, their previous medications, why they've come straight up. Whereas going through a big chart to try and get this information. Actually, Professor Norman is in the front seat there. He helped us from a socio-technical point of view developing this way back. But it's incredible. But we should really know, it would be brilliant, and we know we're putting in genetic data appropriately to it. And but if we had a unique health identifier number, where we had an EHR for every citizen, it would be incredible. We're still in a situation where if a Beaumont Hospital is admitted to Tullamore, with a Beaumont Hospital patient is admitted to Tullamore emergency department, the docs and the ED there have no idea of what's, they don't have access to that data.
And Maeve, I think when we're working with patients that have chronic conditions, and have very complex diseases, it's so important that we can actually access that data.
Yeah, I mean, so we have a fully electronic health record in St James's Hospital, so we're the only hospital in Ireland to have that, and for inpatient, outpatient care, and we have electronic chemo prescribing. The challenge, actually, and I think it's to the question I see on the board here, the challenge is actually how we might be able to utilise that data properly and actually share it. And one issue that separates us in a way is the interpretation of GDPR in the Republic of Ireland as compared to the UK. And that actually affects our cross-border sharing of data as well. So we can gather in an internal firewall an awful lot of data from a fully electronic health record of a very big hospital in cancer and disease as well beyond. But actually, it's sharing that in the absence of explicit consent from every patient for every indication you want to share that's a big, big challenge. So I think that's something probably European level will be addressed, I think, soon, on an EU level. But that, again, to this question I see here about how we allow data flow more freely, I think that our data protection sort of regulations differ significantly north and south, and that's a big issue for us.
Yeah, there's harmonisation there that has been done to some degree, but obviously Brexit hasn't helped anything at all, and that's another area like that. But even with that, it's the interpretation of the GDPR, and it's the policies that are set up around it, and it's the regulations and it's the things that are set up legally. So one of the reasons why we like the open standard approach is that you can then start to hardwire in, if there are governance restrictions in terms of the sharing of data, you can hardwire those into the federation of how those databases are searched. So there are technological, funny enough, solutions to part of this, but at the end of the day, yep, it is an issue, and it's something that I hope our politicians can get their heads around.
I think there's quite a few questions about whole genome sequencing and whole exome sequencing, and differences in that between North and South. So first of all, the criteria used for patients who are sent for whole exome sequencing.
So I tried to give a flavour for that. I thought in my talk where you have patients with unexplained epilepsy and learning disability, or specific pediatric epilepsy syndromes, or a multi-system disorder. So it's certainly individualized, and I think the concept of appropriate testing and appropriate spending of the taxpayers' money is extremely important. So in terms of how we do it in Beaumont, and in the neurology department in Beaumont, it's kind of ad hoc because we don't have any national guidance. And I've explained to our business manager to expect it, and we did an audit on this. One of the fellows did an audit on how much we spend in the neurology department last year on whole exome sequencing, specifically to CGAT. And we spent, this is not just epilepsy, this is me and my colleagues in the neurology department. I think we spent something like 170,000 euros on whole exome sequencing. And I've told our business manager, completely took it out of the air, to expect a 10% year-on-year increase, but again, without national guidance. And it is great that we have the national strategy finally being launched in 2 weeks' time. We just do what we can. And of course, there's different silos, and there's patients who are not getting appropriate testing. So it has been a mess. It's completely ad hoc, and that's why hopefully this is the start of a more robust genetics service system in Ireland.
And I think that goes to one of the other questions here, is when we actually look at cross-border care, is how much can we learn from Northern Ireland, and the establishment of the HSP panel is so important.
Yeah, well, I would have to say that, what you're saying, Norman, is completely familiar to us in genetics as well. It's exactly the same situation where there's still this very ad hoc. It's the ones that come to clinical attention you can make the case for, whereas what we really need is some sort of way of making that initial data grab for the whole exome sequencing. We need to make that a lot easier and a lot more straightforward.
I would say, though, I guess I treat a common disease, right? And your folks more in the rare diseases. So, we do have to be careful, and you make the point, we're talking about clinical care and research, and there is a line between those. So, especially in cancer, when you're talking about thousands and thousands of patients, there isn't currently a clinical indication for whole genome sequencing for patients with cancer outside of the pediatric world. So for adult cancers, there isn't a clinical indication. It might be interesting, and certainly for research, very interesting, but we don't actually need to do it. Similarly with clinical exomes, we don't actually need to do that for the majority of patients with adult cancer diagnoses. What we do need is to do the panel-based type of testing, the kind of core workhorse of what's actually needed in a timely fashion and equitable fashion across the island for all patients. So there's always that tension between what's required for clinical care and for research, and an interface between the two. And cancer is a good example of that, I think.
I think cancer is a brilliant example for that, because actually we did look at that in the 100,000, and that was the lesson that came out really loud and clear. We recruited a number of patients into the cancer realm of that, and exactly what you're saying is that the panels were the way to go. The whole genome sequencing didn't add much to the gig at that stage.
Yeah.
Yeah, and I think, you know, as we move into liquid biopsies, that's going to be there's two cases, which is for rare disease, we need the depth of the sequence information, but for cancer, it's just going to be volume because we're monitoring somatic mutations by and large.
Although I've kind of, I'm a bit skeptical about dividing into common disease and rare disease, because a lot of common disease, like the epilepsies, is often a collection of rare diseases. Intellectual disability is a collection of rare diseases or disorders. You know what I mean? So.
I think it's more germline
volume
versus somatic.
Sort of, germline versus somatic, exactly.
Yeah,
somatic molecular profiling for cancer patients on the island of Ireland, it's a lot of patients, you know, so it's just how we divide that down. And the test directory actually is a really good model of how we do that.
So, so a question here is interesting. It's how much difference would it make to have an opt-out system for tissue samples? For example, all samples for diagnosis may be used unless the patient explicitly opts out.
That system is currently unacceptable under current GDPR regulations in Ireland. So even if I designed a consent form and put it in front of a patient and said, just, you know, opt out, I couldn't use that. It's not compliant currently, you know. There's lots of, I mean, this is again the co-creation idea from our patients. We have to listen to our patients and what protection they want, what information they want, what they're happy to do. I think there's probably a happy medium between a very, 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 very conservative interpretation of GDPR regulations and then a totally opt-out, we can do anything unless you say we can't approach. So I think there's probably an ability to co-create that with our patients. We have to be careful to protect the privacy, especially genetic information. It's valuable information, it's personal information. But then also what we found, at least from our patients with cancer, is that they want their information to be used for research. They want it to be used to help further other patients' treatments and to help us learn.
Okay, and I think we're kind of moving towards to people are going to be hungry and we're keeping them from dinner here. I think there's so many interesting topics that we raised here, and we didn't even get on to talking about the importance of multidisciplinary teams and what we can learn from international experience. And so much of what we do within the National Genetic Strategy will be important cross-border as well. If there's any last-minute comments you want to kind of add here.
No, I suppose going back to the national system, I think, and patients, we need patients' voices, but I think patients are surprised that there is very little sharing of clinical data between hospitals. They really expect that. No, you can talk about opt-out, but patients want their data to be appropriately shared among health professionals around the country. They're not expecting it to be siloed.
No, completely.
Yeah. I just would mention the commonality in terms of the themes across. I mean, we didn't look at each other's presentations before we presented, but there's very common themes, isn't there, across diseases. So I think it's kind of interesting and a good learning point for all of us to see that maybe we are a little too siloed, and actually there's very common themes across many different disease types that we could all learn from each other on, I think.
I think so much so. Thank you.